Hello and welcome to the Acute Medical Teaching Series. This is our second session and we are your hosts,
Shifona
and Harrison, both senior house officers from Salisbury District Hospital.
This will be a 12-part teaching series running over the next 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local Southampton students.
During the second session, we will be talking about the management of pulmonary embolism.
So, what is a pulmonary embolism? It can be a life-threatening condition where a thrombus occludes the pulmonary arterial system. This suddenly increases the right ventricular pressures as the heart has to now pump against an increased pulmonary vascular resistance.
This can result in subsequent right-sided heart failure, lowering the preload into the left ventricle, resulting in hypertension and shock. We know it's quite rare for a thrombus to form de novo within the pulmonary venous system. Instead, thrombi most commonly start as a deep vein thrombosis. If we think back to preclinical medical school days, we know that the formation of clot is related to Virchow's triad, namely vessel wall damage, so this can be things like trauma, surgery or catheterization damaging the wall of a vessel, venous stasis, this can be caused by things such as immobility, surgery or spinal cord injuries, and then hypercoagulability, and this can be secondary to mechanisms such as malignancy, some medications such as the combined oral contraceptive pill, sepsis, and other inherited thrombophilias. These above factors lead to clot formation and become important later on when we start to think about risk stratification scores for pulmonary embolism.
So let's have a look at signs and symptoms. PEs can often present atypically, but we know that 97% of patients with a PE will have one of the three following symptoms: acute onset of shortness of breath, pleuritic chest pain, and features of a DVT.
It's also important to be aware of the atypical presentations associated with pulmonary emboli. We know also other symptoms can include things such as low oxygen saturations, risk factors for underlying PE, such as a patient who's been immobile, recent operations or previous PEs in the past, cough, hemoptysis and fever. And interestingly, 10% of patients with a PE will have a fever.
Patients with PE can also present with hemodynamic instability, defined broadly as a systolic blood pressure of less than 90 without alternative cause. These require early senior support and will often need thrombolysis and anticoagulation, and may need to go to ITU for organ support.
So what can we use to help us diagnose a pulmonary embolism? If you have a low clinical suspicion of a pulmonary embolism, you can use something called the PERC rule. This is the pulmonary embolism rule-out criteria to help you exclude a pulmonary embolism. And there was a big meta-analysis that looked into the PERC rule, and it found that in the ED population, it only missed 44 out of 14,844 cases, so about 0.3%. For the PERC score to work, however, you need to have a score of 0 to exclude a PE, and you can see the scoring system on the screen now. If not, you then need to progress to the next scoring system called a Wells score.
If you have a high clinical suspicion of PE or the patient does not meet the PERC rule, you can use the Wells score, and you can see the criteria as shown on the screen. So 4 or less on the point system means that the PE is unlikely, but greater than 4 would mean that PE is likely. If a patient scores greater than 4, it means that they will need further imaging to exclude a PE. You should start anticoagulation in the absence of any contraindications. The most likely imaging will be a CT-PA, CT pulmonary angiogram, which is a protocolized CT that looks at the pulmonary arteries in more detail. If a patient scores 4 or less, then you should order a D-dimer test. If the D-dimer is negative, then you have effectively excluded a PE, and the risk of PE within 3 months of this group is less than 1%. If not, then you should progress to the imaging for PE, so your CT-PAs.
So we talked lots about D-dimers in medicine, but essentially it's only a useful test for excluding a PE in the context of the Wells score. A positive D-dimer does not confirm a PE, and there are multiple causes of a raised D-dimer, including things such as an underlying infection or malignancy. It is important to note that if the patient is over the age of 50, you should also age adjust the D-dimer using a site such as MD Calc, as elderly people typically have higher baseline D-dimers.
An ECG is often also performed to help with the diagnosis of PE, as it helps you consider alternative causes of chest pain, so for example ACS. The most common rhythm seen is sinus tachycardia on an ECG in PE, but you can also present with AF, S1, Q3, T3, new right bundle branch block, RV strain pattern, or even a normal sinus rhythm.
And next we're going to talk about chest x-rays. So chest x-rays offer a good screen for alternative causes of chest pain, such as a pneumothorax or a pneumonia. It is usually normal in a patient with a PE, so you'd expect to see clear lung fields. But of note, if the pulmonary embolism has led to an infarction, this can be difficult to distinguish from pneumonia on a chest x-ray, as this too will appear like a patch of consolidation. Therefore, if you do see consolidation on a chest x-ray, it does not exclude PE.
VQ scans are an alternative to CTPA, particularly for patients with a contraindication to CTPA, such as contrast allergies, impaired renal function, or young patients. VQ scans are, however, difficult to interpret in the context of an underlying lung or cardiac disease, so CTPA is still the preferred option, especially in older, more comorbid patients with multi-system disease.
Next, we're going to be talking about the management of PE, and the management of PE can broadly be divided into two groups, those who are hemodynamically stable and those who are hemodynamically unstable. So those who are unstable generally are considered very high risk and will need discussion with a senior doctor. And we know a PE is unstable, as we mentioned before, if that systolic blood pressure is less than 90, but also other things that can suggest a high risk PE include things like a saddle pulmonary embolism, where the pulmonary embolism arches over both sides of the left and right pulmonary artery. If there's significant right heart strain, and you can sometimes see this on the CT scan or an echo, where you see the right heart bowing, and this suggests that it's in trouble. Also, if there's raised biomarkers, so evidence of cardiac strain, and this is things like a raised BNP and a raised troponin. These suggest that the heart is currently struggling and suggest that the heart may be approaching failure. Or if there's significant oxygen requirement, so a patient who's got a PE with SATs of 85 on air is obviously very poorly. So when we think about the management of these patients, we generally consider oxygen therapy. We also consider giving them IV fluids if their jugular venous pressure is not raised. So if you overload these patients with an acute right-sided heart failure, you risk tipping them along the Starling's curve, which can further reduce their cardiac output. So you need to very cautiously manage these patients. If their JVP is not elevated and their blood pressure is low, you can absolutely give these patients slow, cautious fluids, but you need to be careful that you're not tipping them with regards to their physiology. And then we talk about primary reperfusion and anticoagulation, as these are essentially going to be the things that fix this PE. So primary reperfusion means giving a medication to break down the clot, which most likely is going to be alteplase, and then anticoagulation after this with an unfractionated heparin. We can also consider ITU support for these patients, especially if we're having difficulty managing their fluid status due to the right-sided heart failure. They can consider things such as vasoactive medications, such as adrenaline and noradrenaline, to help increase the blood pressure whilst not tipping the patient into further heart failure.
If the patient is hemodynamically stable, we can use the PESI score to grade whether we can manage these patients as an inpatient or an outpatient. If the PESI score is 3 to 4, these patients are often managed as an inpatient. Anticoagulation is the mainstay of treatment, which is normally a low molecular weight heparin or a DOAC, with referral to the anticoagulation team for further management once the patient has been discharged. The time frame of treatment depends if the PE was provoked, in which case it will be 3 months, or unprovoked, in which case it will be 6 months of treatment.
So an unprovoked PE would be a patient who is normally fit and well, walking around, who spontaneously gets a PE without any other risk factors. Whereas in a provoked PE, we would see risk factors such as surgery, prolonged immobilization, an underlying malignancy, or other risk factors such as transatlantic flights. The thing we worry about with unprovoked PEs is they may be suggestive of an underlying condition, so further investigations are sometimes warranted. And NICE guidance actually suggests that these patients receive a full cancer screen, including considerations for a CT chest abdo pelvis with a mammogram if female. However, the evidence supporting screening for undiagnosed cancer after unprovoked venous VTEs is mixed. And therefore, there's been kind of ongoing studies in this patient group that have implied the best approach is to take a thorough system screen and perform a physical examination of these patients, looking for any evidence of an underlying malignancy and a review of the bloods. If you identify any suspicion of underlying malignancy, then you should refer them to the onwards appropriate pathway, e.g. a 2-week wait.
Patients with unprovoked PE will also be referred to the thrombophilia clinic, where hereditary causes of VTE will also be considered, such as factor V Leiden deficiency and antiphospholipid syndrome.
We hope that this educational session has been informative and that this information helps during your time at Salisbury District Hospital. Make sure to stay tuned in for more educational sessions. That's it from us, your hosts,
Shifona
and Harrison.
See you next time.